morning and I'm taking a bedside around on a patient who's undergone a bypass. And on the bypass, patient has undergone an uneventful surgery, and patient is doing reasonably well. His blood pressure is stable, his pulse is stable, the drain output is pretty stable, nothing much. The urine output is pretty good. The investigations that have come by in the morning are also stable. But when I did come and see this patient, overall patient is actually getting better. The lactates have actually come down. So the lactates which is slightly elevated have also come down. The bicarbonates are normal. And the morning investigation showed no electrolyte abnormalities. But when I came and saw this patient, what I see is that there is an ECG pattern that is pre-operative. There is an ECG pattern that is pre-operative, which shows a normal sinus rhythm with a P that is followed by a QRS complex, but the T wave inversion is in the anterior leads. So you have anterior leads V1, V2, V3, V4. In fact, all the leads are global T wave inversions that we are seeing all across the ECG. There is no arrhythmia. Okay, there is no arrhythmia, and the R wave doesn't seem to be progressing. The R wave is progressing, but not very well progressing. So you have 1 and 3 slight axis deviation also is there, but this is what it is. This was pre-operatively. Now what has happened post-operatively? Post-operatively, I see an ECG that looks like this. Now when I see an ECG that looks like this, I'm actually seeing a sudden change from the earlier ECG, which shows that there is a very tiny Q wave in 3 and AVF, not really very significant, though it is a Q wave. It's a very small though Q wave. What we're also seeing is that there is a cutoff of the R wave. There is no R wave happening. V1, V2, V3, V4, V5, V6, the R wave is actually absent. There is no R wave progression at all. In fact, this looks like a QS pattern. V2, V3, V4, this looks like a QS pattern that is seen. Now, when do I see such patterns? Also, we can see a slight upstroke convexity on the ST segments that we are seeing over here. Slight convexity is there, and ST segment convexity is there. Now, the earlier ECG was this, and now just immediate post-op you're seeing something like this. So few things that come to my mind first is because of the fact that the limb leads are actually normal. The first thing I'll see whether there is a technical issue in lead placement, because I don't expect a sudden change when the patient is actually improving. So the first thing is technical placement. So I've actually done a repeat of this ECG, and when we did a repeat of the ECG, what I do see is the fact that there is the same kind of pattern that we are seeing, the same pattern. So one thing is that this is not a technical problem. Now, on the background, when I go back and see all of these things, what could this be? What are my differential diagnoses? My differential diagnosis is A, that this ECG is significant when it comes to Lima LED graphs. When the Lima LED graphs or LED graphs are occluded, in any way the LED graphs are occluded, there is a high possibility that the LED is infarcted, the LED territory is infarcted. And when the LED territory is infarcted, you see large anterior wall myocardial infarctions. But then such a patient who is post-operatively will not be stable. If a patient like this is there, the patient will not be stable. These will be those patients that will be crashing, BP falling, lactate rising, bicarbonate dropping, and urine output dropping, and your supports going higher and higher. This is exactly not this patient. This patient is actually improving. Lactates have come down, the BP has got better, the oxygenation is very good, patient is not complaining of chest pain. So it kind of rules out, clinically at least, that this ECG is signifying LAD or graft occlusion or graft giveaway or something like that. What are we dealing with if that is the case? The other thing that you can have is apart from that, could be also just perioperative MI. If it's a perioperative MI that is occurring over here, a perioperative MI could also show something like this. However, there again, the patient will have chest pain. The way you can figure out is by sending troponins and seeing its dynamic rise per se. Okay, something like that also can be seen in such cases per se. But definitely it's not a normal ECG. The third is that you have an ECG that looks like this, where preoperatively if patient had an ECG that was normal, or T wave inversions would be LV aneurysm. If an LV aneurysm is there, the ST segments could be all the time up and the QS pattern would be there, but that would be obvious on when they did the bypass. They've completed the bypass, they did not find the LV aneurysm. So it's very unlikely that this is LV aneurysmal per se. Okay, I have this. Patient is improving, patient is doing okay. What is my next step as a doctor in the intensive care unit? Two things I can do. Number one, I will immediately get a 2D echo screening to see what's happening on the 2D echo. And second, I'll send a troponin just to be certain that it is not perioperative MI. All said and done, my patient is stable. It doesn't stop me from extubating my patient. It doesn't, because this patient has passed all weaning parameters. If my echo is normal, If my echo is normal, this does not stop me from extubating these patients, because in this kind of large territory heart failure infarcts, the patient will actually have very poor EF, because left ventricle is the most prominent ventricle among the left and the right. Clear? This is how would I interpret this particular ECG. Okay.